Hello, everyone, and welcome back to Echo Asthma Bootcamp. My name is Ashley. I'm your facilitator. I'm joined by my coordinators, Rachel and Tabitha. We have our wonderful hub team, Dr. Meredith McCormack. We have Andrea Jensen, certified asthma educator, and then I will let Aaron Sutton introduce himself.
Thank you, Ashley. Good to see you. So as Ashley said, my name is Aaron Sutton. I am a clinical social worker. I'm trained as a psychotherapist, and I work as a behavioral health faculty in a family medicine residency program in Abington, Pennsylvania, right outside of Philadelphia.
Thanks so much, Aaron. And Aaron always joins us for this session in particular, because today we're going to talk about shared decision-making in severe asthma. So let's get started with our lecture on shared decision-making hosted by Dr. Kerr.
Hello, everybody. Welcome to session 5 of the Echo Asthma program. Today, we'll talk about shared decision-making in severe asthma. My name is Dr. Sucharita Kerr. I'm an assistant professor at Tufts University School of Medicine in Boston and an adult pulmonologist with an interest in asthma at Tufts Medical Center. So what is shared decision-making? Shared decision-making involves really two participants. It's the physician or the healthcare provider and the patient, where mutual sharing of information occurs, including the patient's values and preferences, to build consensus about favored treatment that ultimately culminates in an agreed action plan. It has been shown to improve clinical outcomes as well as quality of life by educating patients and empowering them to be really actively involved in their own health. It's often thought about as a two-way communication, where the clinician discusses what the patient has, the diagnosis, what the potential treatment options are, what the risks or the benefits may be for that treatment options, and what they would expect once the patient starts that pathway of the treatment. On the other side, the patient will discuss the values, what's important to them, what they prefer, what their opinions are about certain treatments or procedures, and what their lifestyle may be. And then together, taking both aspects of this into account, a shared decision is made. Now, it's important to note that this decision may happen in one visit, or it may take a series of visits for this to happen. And it's really important to also note that this is not necessarily a give and take, but really a discussion, a collaboration between the clinician as well as the patient. I'd like to highlight this with one example. So after discussing with the patient, the physician may realize that they may choose to substitute a current prescription that the patient has for a less expensive medication, mainly because cost is a big barrier as to why the patient is not necessarily adherent with the medication. And it may be that the replacement that the clinician prescribes may be less effective, but actually a drug that patient can actually take because the patient can now afford the drug. And so really it's having these empathetic conversations with the patients that allows us to really understand what their values and preferences are, that ultimately gets the patients engaged as well as empowered in their treatment plan. And there are many benefits to shared decision-making model. It is shown in studies to improve adherence to medication by the patient. It improves patients as well as in terms of kids' parent satisfaction. There's less indecision from a patient standpoint because now they're much better informed. There's improved patient knowledge. There's improved patient-provider communication. Clinically, there's better asthma control, higher quality of life scores, lower asthma-related healthcare visits, and overall healthcare costs. There certainly are some challenges, and so studies have shown that providers perceive that shared decision-making takes too much time, when in fact, the studies have also shown that consultation time increased by only about 3 minutes or less when a shared decision aid was used. So there are certain factors that we can use to actually allow us to help to come to a valid shared decision-making visit. There may be perception that the provider is already involving patients in decision-making, But studies show that clinicians elicit patient agendas in only a third, about 36% of encounters. And even when they do, on an average, clinicians interrupt the patient as soon as 11 seconds, not allowing them to speak further. And after asking the patients to express their concerns, this study showed that clinicians listened to them only for about 18 to 23 seconds before interrupting. And so there's certainly opportunity to do better for our patients. Clinicians also may incorrectly assume that their patients want and expect their healthcare provider to make decisions for them. In reality, most patients desire their own input and want to provide their own input for the healthcare decisions that's going to affect them at the end of the day. And so if you look at the GINA guidelines, they recommend that the long-term goals for asthma management are, one, to assure good control of their symptoms and to allow maintaining normal activity levels. And second is to minimize the risk of asthma-related death, exacerbations, persistent airflow limitation, and side effects, which is true for anything. Our role for patients is to make them feel better, make them live longer if we can. And so, but GINA guidelines also recommend that it's really important to elicit the patient's own goals regarding their asthma, as they may differ from conventional medical goals. And that shared goals for asthma management can be achieved in various ways, bearing in mind differing healthcare systems, what medications are available, as well as cultural, as well as personal preferences. Patients may have preference for IV or subcutaneous administration. 4 out of the 5 FDA-approved biologics are administered subcutaneously, and one of them, rosalizumab, has an IV administration route. This is a cross-sectional study. It's an observational study of 150 patients attending an outpatient pulmonary clinic. These patients showed that about 18% had a preference for IV versus over 80% preferred the subcutaneous route. These patients felt that subcutaneous was more convenient than IV, but the belief was not associated with the higher likelihood for preferring a subcutaneous administration, interestingly. Also, IV formulations were thought to be more likely associated with a quicker and a more effective drug action, procedural safety, and medical oversight and social support. However, this may not necessarily be true. Thus, the preference was guided by partially misleading beliefs, which ultimately may generate wrong expectations that in turn may affect treatment satisfaction and adherence down the line. And so as clinicians, we should really be aware of the possibility of this cognitive bias among our patients in order to be able to provide them with accurate information and for health education. Beliefs towards convenience and efficacy of drugs with different routes of administration should be formally elicited and discussed during that doctor-patient or clinician-patient interaction to achieve informed decision-making. And so there are things that can potentially be done to also reduce injection-associated anxiety. There have been evidence-based methods for reducing needle fear, and these include exposure therapy, including instruction, modeling, and targeting of catastrophic thoughts to reduce the fear in adults, and CBT, or behavioral therapy, or cognitive behavioral therapy, hypnosis, and breathing interventions may also help reduce adolescent distress. Now, there may be various factors that should be considered, both on the patient's side as well as the physician's side. And so let's bring this shared decision back to thinking about how it impacts patients who we are considering biologics for, our patients with severe asthma who we want to start on biologics or who we are recommending biologics. So this was a study that was published more recently last year that asked patients as well as physicians what was important to them in this context of starting a biologic for severe asthma. And for patients, it was, not surprisingly, out-of-pocket costs, the mode of administration, how long it would take to achieve peak effect, so the time of onset to efficacy, and what administration setting it was. While on the other side for physicians, it was more important to know the mode of administration, certainly the time of onset of efficacy, how long it's going to take to get my patient feeling better, the dosing interval of frequency, as well as a lot of questions around insurance reimbursement as well as access. Both groups, patients as well as physicians, preferred less frequent administrations. For example, every 8 weeks compared to every 4 weeks or every 2 weeks. And also subcutaneous over intravenous administration of biologics. And so certainly the Chest Foundation and the Allergy and the Asthma Network have provided us with decision aids that I would certainly encourage you to review and look at. The website is right there at the lower right corner, and use it to your advantage and to your patient's advantage when you're having these conversations with the patients. And that's really where personalized medicine comes in. We have lots of good treatments for asthma as well as severe asthma. A lot of these are based on the patient's particular phenotype and endotype, but it's really combining the available targeted treatment for severe asthma along with the shared decision communication model that allows us to really personalize medicine in patients with severe asthma. Thank you for listening, and we'll open this up for some question and answers.
All right, thank you everyone. Thank you, Dr. Kerr. Dr. McCormack, what do you feel are our key takeaways from this lecture?
Well, I feel like I'm really excited to hear Erin's contributions to our discussion today. But really, I think asthma is a great example of a condition that's common where shared decision-making is so important. And some of the barriers and topics that were addressed included cost of medications, which in my practice is a huge issue, adherence and how people take medicines, because I think inhalers tend to just feel and seem different to our patients. And so sometimes they don't even always think of them as part of their medications. They think tablets are more traditional medications, and then really understanding each individual's barriers and how they're approaching therapy so that they can be engaged in the approach and really buy into the treatment and having that open communication. So I think it's a great topic for today. I'm excited to hear from the group.
Thanks, Dr. McCormack. Erin?
And I think what Dr. McCormack said was, really trying to identify those barriers as well. And something that Dr. Kerr said, which I think is very important, is this may be a series of visits, right? This doesn't have to be in one visit. And I think, as Dr. McCormack was saying, we try to learn those barriers after several visits to find out what is going to be most effective for the patient, as well as for us. And we're really trying to find those values and the values that we have as a clinician and the values of the patient and how we can make those two interlap. I like to talk about a technique used a lot in cognitive behavioral therapy, which was mentioned toward the end of Dr. Kerr's lecture about needlephobia. But I want to talk about something called collaborative empiricism, which is a technique used in CBT where we are not the authority figure in somebody else's life. We're a participant in their life, right? So we actually sit down with the patient and say, here's what your past experiences have been in treating your asthma. Here's what some of the outcomes have been in having your asthma treated. And it sounds like some of the goals and values that you have in wanting to have your asthma treated. Here's what I can offer. Let's see if we can create a hypothesis together and treat your asthma going along this route. I think that really works well for patients because, again, as Dr. Kerr said, it has patient buy-in, right? You're not just listening to what somebody else said, which is this is what you need to do to get these results. It's I've actually put my own 2 cents into this equation. And if it doesn't work, we'll come up with a plan again to see where we go to from there. So I love that aspect of that collaborative empiricism. Together, we take an experiment, try to see what happens in it, look at our results, and then change if need be. I think that's always really crucial as we're talking about shared decision-making. I think it's also important to look at the past experiences that the patient has had. I know I mentioned that with collaborative empiricism, but I'm curious as to how the patient was in their treatment before this. Have they had an active voice in it? Have they been a participant? Because I think lots of times we hear that somebody has been on a regimen and perhaps they didn't understand what the regimen was. And I think we hear from Andrea about, all the ways that people don't really understand their medications, but were they told this is what they should do and this is the regimen they should be on, and then we find out they don't really understand how it should be. And now we're in a place where we have to start changing that. The second thing I want to talk about as far as, shared decision making, especially from a cognitive behavioral approach, is that systematic desensitization, which is how we approach needlephobia. And I think lots of times, again, if we ask people what their experiences are with needles, we're going to get a varied response. And lots of times, this is something that can be done with one visit, right? I think lots of times people have an expectation of what a needle is going to look like, or how it's going to feel, or how much medication is going to be in it. And they have no idea, right? Not until they actually see how the medication is going to be used do they have an understanding of what it's going to be like. And there's research that shows that in as little as 6 visits can reduce somebody's needle phobia to where they are actually ready and willing to take something that's going to be beneficial for them. So again, we actually use both of these techniques together, this collaborative empiricism, and then we look at, if we do go this route where you have to have something that's injected, we'll look at systematic desensitization again in our treatment plan. So this is a great topic. I'm curious to hear from the group as well and some of their experiences about this. I'm always welcome to hear what Andrea says. I know that, I learned so much about medication. And again, I always wonder if, that's something that we can spend a few more minutes on with the patient and say, let's really make sure you have a grasp of how your medications are. Because then if that empirical hypothesis, if we do that empirical experiment, if it doesn't work out, then we know that we gave it a really good try and we're going to try something else now.
Erin, I love that. That was a lot of great information. Oftentimes by the time someone's referred to me after they've been at one of the clinics, they're not compliant on their medication. So, and really to tease and really get to the real information, and maybe I've mentioned this before, is we say, most people remember to take their inhaler 2 or 3 days a week. And about how often do you remember to take yours? And they'll say, oh, well, I take mine 4 days a week. And then, well, do you have the real answer there? Instead of saying, if you just come out and say how many days a week you're taking it, well, of course they're going to say, well, I take it every day because that's what I'm supposed to do, right? So to get the real answer, and then when they start to talk about it, say, well, tell me a little bit more about that. And that is my favorite phrase of all time. Tell me a little bit more about that. That really opens it up, and I'm able to tease out why it is that they're not taking their medication. Is it too expensive? Do they not like the dry powder inhaler? Would they prefer to be on a meter dose inhaler? What's going on? Are they just forgetting? Do they not want to be on a medication for years and years? Is there something there? So that's one phrase I really love to use with the people I work with. And so then I can help them kind of solve that. And Erin, as you mentioned, really being a partner with them. I'm not coming in as the authority figure. Well, you need to do this and this. It's like, okay, well, maybe I can help you figure out a few ideas for this. And so that partnership's really important.
Thank you so much, Andrea and Erin. We have another wonderful resource from Andrea in the chat, a little bit more about needlephobia, which I'm sure we will add into our resource center. Do we have any questions about the lecture or anything that Erin or our hub team have mentioned, or suggestions of techniques that you use in your practice?
Hi, this is Louis Goritsky. Can you hear me?
Yes, we can. Hi.
Hi, I'm sorry we lost internet. I'm in Florida and we're having a thunderstorm right now and I don't have internet to sign in. But I did want to share a few thoughts with you on the topic. First point is, patients are entitled to make decisions that healthcare professionals think are the wrong decision. We are not the health police. All we can do is provide enough information with the bias of science to enable another person to decide whether they think what science says is best is indeed best. And sometimes patients are smarter. And remember, we have many situations where we tell a patient what the best choice is, and they have a bad outcome from the best choice. So if we had a crystal ball that would be able to tell for an individual what an outcome is going to be, that would be wonderful, but we don't. We have it only for populations of persons, and the person who's sitting across the table from you, they may not fit that particular population. There may be something very special, distinctive, singular about them that makes the model of a general population not fit. And then a couple other thoughts about reality testing. There was actually a study published in New England Journal, 2007. The first author is Poppy, P-A-P-I, and the authors were comparing for people with mild persistent asthma, should people take maintenance inhaled corticosteroid or PRN? And for the outcome that they chose for peak flow, the people who took their inhalers on a PRN basis, their steroid instead of every day, at the end of the trial, there was really no difference. And what patients ended up doing was saying, look, you guys tell us we're supposed to take this every day, but it costs us more money. It's inconvenient. And what we find out is when we forget and don't take it as recommended, we don't feel any different. So why should we bother to spend more money and take it as you said we should? So I think we need to be very careful when we lead a person through the decision process. We also know that there's language that is not universal. This began with the North American Menopause Society. They were talking about women taking hormone replacement therapy. Clinicians were describing what the risks were, like breast cancer or venous thromboembolism. And clinicians would use words like rare. And the patient was left to wonder, well, what does rare mean? Does that mean you've never seen it before? It happens to 1 in 10,000, 1 in 1,000, 1 in a million. So we are oftentimes conversing with a level of confidence that we know what we mean, but the patient doesn't. Oftentimes, I think my most powerful tool really comes from my heart, and that is when I have a patient who's my age, I say, if you were my brother or sister, I'd recommend this for you, and here's why. If the patient is much older than me, I say, if you were my dad, if the patient's much younger, I say, if you were my son or daughter, here's what I'd recommend of them on these decisions and why. And that's because I really do believe that most patients don't want to feel like the disorder that walked into your office. They want to feel like a whole person, and that you recognize the whole person the same way you would recognize the needs of a family member. And then the final point I'd like to make is we know there is good reason for certain groups in our population to distrust clinician advice, especially for Black Americans. There is historically rationale to distrust non-Black physicians. So overcoming that boundary, that barrier of establishing trust is not a minor issue. So I wish there was a simple formula that you could say, take step A, B, and C, and the proper result will happen. That is not the case, even in the best of all circumstances. I think that as we progress in science and in behavioral health science, we're beginning to learn things that will head us more and more in the right direction. But I think the expectation of patients always doing what is in their best interest, despite the best efforts of the clinician, is not something we're going to see anytime soon.
Thank you, Dr. Koritsky. Do we have any other comments from our hub team or from any of our attendees?
You know, just one more thing. At the very end of our asthma home visit program, one thing that we always leave our patients with is we say, please follow up with your doctor. And these are the questions that you can ask. Because we want them to know that, you know, sometimes you have to tweak asthma medication. Sometimes you need a different dose or something needs to change a little bit. And we always give them the poster of all of the inhalers from Allergy and Asthma Network and say, there's a whole rainbow of options here. And I know you may be limited based on insurance, but please follow up and let's see if you need to tweak it a little bit. We'll see how you feel. You know, I'll talk to you again next month and I'll see how you feel. But really, this isn't the end. This isn't the last one. If they're not feeling like something's right, by all means, go back and see if they can change their treatment a little bit.
Thank you, Andrea.
I was just typing that while you were talking, Andrea. It reminded me of what we both were talking about in their first session. I think I have a typo in my second one, but basically just, yes. I feel like this tool really helps me to ask in an open-ended way. And just similar to what you said, I usually ask them which medicine they're taking. And then I have some kind of stem, like most people don't remember to take their medicine every day. Do you think you get, like, what do you think you get in? And if they're kind of looking at me, I'll say, you know, do you think you take your inhaler once a week, or like start low and then, or half the time. And then if it's half the time, is it once a day? And then kind of giving them the ability to say, yes, I only take it even less than half the time, once a day instead of twice a day. Sort of just giving a little bit of permission to be, or encouraging people to be really honest.
Yeah, I want to reinforce that with the idea that patients want to be so-called good patients. They both want to please us and they want to avoid chastisement. We know that because there's studies in diabetes where people are supposed to keep a glucose log and they fill it out in the parking lot before they come in. They write in a whole month's worth of glucose because they don't want to be punished for not doing it. And they also want to please us. And I think there's ways that we can capitalize upon those feelings on the patient's part by reinforcing them for doing what we agree to be the optimum things.
I have the pleasure of being able to work with Cindy Rand, who's one of my colleagues, and she's done a lot of work in adherence to asthma. And I think they published a paper about the parking lot effect for asthma inhalers with the counters, where people will, either in research settings or in clinical settings, just try to make the counter go down by actuations in the parking lot or in the car. And sometimes, especially with the right patient, I'll say that to some of my kids have had to use inhalers, so I'll offer that up, just that, I often remember how often my kids are supposed to be using their inhalers when I'm driving them to the pediatrician and thinking about the questions they're going to ask, and realize that, we haven't had a perfect system. So.
And I have one question that I guess really for you, Dr. McCormack, as well as, other clinicians on the line, as far as using decision aids in a visit with somebody, right? And it sounds like what you and Andrea were talking about is having those open-ended questions for somebody to answer, right? And how that may differ than if you gave them a questionnaire that said, how often are you using your inhaler? To, to fill it out before you come into the exam room. And that's going to vary from fill this out to I come in and say, hey, lots of people take their inhalers once or twice a week. How many times? Do you find that impedes the length of time you're in a visit with somebody? I know that Dr. Kerr's lecture said that, around 3 minutes or so, increased consultation time if you're using decision aids. And I think that as a part of that collaboration, do you feel that's important to do? Is that something that, we would encourage other people to do as well?
I think for me, that visual aid saves me tons of time. And I get so much useful information. Even if it didn't save me time, the information is so helpful. And a couple examples. So one, in asthma in particular, a lot of people get confused by how they're supposed to use their inhalers, whether it's a maintenance everyday inhaler versus an as needed rescue inhaler. And in particular, ProAir and Symbicort are both red, for example. And so that's, people will often get those confused. And if they happen to be on both and they point to the red inhaler, I'll ask how they use it and how they might be able to distinguish between the two. And so that just starts a conversation that I think brings back the real world a little bit into the clinic setting. And so I find that also that can, sometimes I start with that and I don't always, but that can also just start the conversation about level of control. For example, if they're reaching for that rescue inhaler, the as needed inhaler quite often, then we can segue into that. So I find it a very useful tool from a time standpoint and just an information gathering.
I think there's another advantage to the decision tool, and that's simply for completeness. We still know that pilots have a checklist that they have to attend to each item on the list before they take off. And that's simply because of the frailty of human memory, or the ability for all of us to participate, no matter how well we know something, to miss a step. When I use a decision aid, it makes sure that I address at least the fundamental critical issues for each patient, as opposed to if I'm just having a simple discussion and something might distract me or cause me to eliminate a step that might be very important, but the decision aid is programming in the critical steps that should likely be addressed for every patient. That way I don't miss it.
Thank you, everyone. All right. So do we have any final questions from our group for now? Otherwise, we can scoot on to our patient case. Thank you, Andrea. We've got stickers available for inhalers for differentiation between controller and rescue inhaler, which is great. We'll make sure that we add that. Iggy and the inhalers, that's great. That's great. All righty. Well, let's scoot on to our patient case. This one will be presented by Dr. McCormack.
So this is a patient of mine. She is 66 years old. She developed or became more aware of symptoms of asthma when she was in her 50s. And she, her profession is that she trains and shows dogs. And this is also her passion. And when I first started seeing her, she noted that she had, when she described her course and times that her asthma was worse and really had progressed quickly to exacerbations that were pretty profound. A few times this happened in the setting of large dog shows where she would be in what she described as not really a convention center, but some kind of arena where there was a lot of animal, what I, in my mind, thought of as like animal dander and dust and so forth. And she really had strong reactions in this setting and had been doing this for her whole life, but this was sort of escalating. Her symptoms, really, as we got into the details, she had symptoms daily, and these were symptoms of cough that was often productive of clear sputum, but not always productive of clear sputum. It wasn't discolored, wasn't even really white. It was typically clear. When she got these more serious or more profound events, she would certainly have chest tightness then, and she would have sort of a twinge of it on milder days. She acknowledged that she tended to minimize her symptoms and didn't really like to take medications, and that became clear as I got to know her. She had symptoms most days of the week and did wake at night probably about once a week with symptoms. She had seasonal allergies and had features of allergic rhinitis, postnasal drip. And I wrote yes to skin testing, but really she had RAS testing, which I'll share with you in a moment. So she had a blood test for specific IgE sensitization. She responded somewhat to beta agonist therapy, and particularly when she was having a very hard time, she would certainly reach for it for albuterol. And she took it with her when she would go different places to do activities related to her occupation, beyond just like the large dog shows, but also when she was working and so forth. But she really tried not. She would use her medications when things got really bad, as she would describe. She had responded and had improvement in her symptoms with systemic steroids in the past, and had been on, had 1 to 2 steroid courses in the last year when I first saw her, but again, tried to avoid medications like very strongly. I wrote her triggers were certainly pets and animal dander and dust and things related to her occupation. She also noted symptoms of chest tightness and shortness of breath at times with exposure to very cold air. And she was on Brio, fluticasone, Vilandrol at the higher dose, 225. We end up starting that and moving her to a once daily dose over time from a twice daily inhaler. She was on Montelukast, albuterol is needed, and she had been treated with Xolair in the past, as well as had seen allergy and received allergy shots in the past, but wasn't on those therapies when I saw her initially. She had also tried Spiriva and didn't appreciate a benefit with Spiriva. This should be yes. She reported quite openly lack of adherence, and I can talk a little bit more about that. She had missed work and reduced physical activity because of her asthma symptoms, and had not This actually is a no. She hadn't been hospitalized, but she had taken prednisone recently when I first saw her. She is a never smoker. She doesn't vape or use any electronic tobacco products or have any other habits or settings that she would be exposed to dust, gases, or fumes, but besides what I have told you. No history of drug use. Really doesn't have any other significant comorbidities. She had a family history of asthma. And her labs, her IgE was just over 100. Her white count was normal, and her eosinophil, her absolute eosinophil count was 260. And her RAS testing showed sensitization to dog, to cat, to house dust, ragweed, and mugwort. She had spirometry. She actually had full set of pulmonary function tests, and her FEV1 was reduced at 67% predicted with a low FEV1 to FVC ratio of 68%, which was consistent with a moderate obstructive defect, and she had a normal gas transfer. She had a normal DLCO, which I had checked early on. She did not have any bronchodilator response. She didn't have improvement with bronchodilator at this time and on repeat testing a year after I initially saw her. And these numbers were pretty consistent. On exam, she has had intermittently expiratory wheeze at different visits and had this on her first visit. Otherwise, her exam was normal. So a couple questions. I think there are a few things to talk about, but one of the things might be how we would address the role of the environment in this patient's care, and that's been a challenge for the two of us, and a challenge for her really, because her passion is dogs and showing dogs and everything about the work that she does, and but she was quite aware that this seemed to be becoming more and more of a trigger. And also the role of adherence to medications, I think is another thing to talk about with this patient. And then we could talk about whether a biologic therapy would be something to even have on the table.
Thank you, Dr. McCormack. All right, we are open to suggestions from the group.
You know, one of my first thoughts was just looking at her age and where she didn't seem to have problems until later on in life. And I'm wondering where she is with menopause, since we know that that can be a particularly difficult time for women. And I'll put an article in the chat here, but we know that their death rates are 4 times higher than any other age group. So, you know, wondering if hormones are always fun throughout our lifetime, if that could be affecting her asthma. I don't know if allergy shots would be an option for her to help her desensitize to the dogs. Clearly, this is something that she loves to do. If I go into a situation where I know there's going to be an issue, oftentimes I'll pre-medicate before I go, take a couple puffs of my albuterol before I go in. But yeah, this is her passion. We got to figure out how to make this work for her and how to protect her and keep her safe.
Anybody else have any other thoughts or comments about her care?
Well, I think people are focusing on her dogs, and that should be a prominent part of the picture. But there is a concept called the allergenic load, where things conspire together, and then maybe one individual point will push people over the top. So you heard Dr. McCormack mention that her allergies were positive for dust and ragweed, mugwort. And even if we don't get successful desensitization of the dog, it may be that desensitization and environmental manipulation for the other allergens could have a big payoff. If we could reduce her IgE in responsiveness of her mast cells to IgE dramatically by desensitizing the other items, that might be really beneficial to her.
That's a really interesting point. She really had these profound episodes that I think, to Andrea's point, were scary when she would describe them, because I think she really lived pretty chronically with a fair amount of symptoms that other people might have thought were unacceptable, but were acceptable to her. And then what really brought her to be more aggressive about following up and getting care for her asthma were these significant and profound events that she had in arenas where she was showing her dogs. And as she described it, there were a few events a year that would be this large. And as she described the setting, there was a lot of dust. I almost thought of like, you know, being in a circus tent or something like that, where there's like tons of dust. And she was describing, you know, that this isn't only used for dog shows. These places are used for other shows or animal related events. And so there could be all kinds of allergens there beyond just dust. She had an extraordinarily high IgE actually to cat. Her dog one was sort of low. Now those things don't always, don't always track to clinical context, but I thought that was interesting. And then just the dust itself as a trigger. So one of the first couple things we did was really just talk about the medications and at least get out on the table. And she came to this conclusion as well, but kind of naming it that she was someone who didn't want to take medications, probably minimized her symptoms. And so we tried to just be a little bit more quantitative about her symptoms every time I saw her. So maybe just for me, I don't know how helpful it was, but reinforcing that cough she's having every day, the nighttime awakenings, that chest tightness that's a little bit low level, those are all symptoms of poorly controlled asthma. And just reinforcing that over time. We did, I think, made some headway with improvement of her inhalers in terms of adherence to inhalers. And I think she appreciated a benefit there. And ultimately, she actually tried to make some changes in her schedule so she would avoid those really big events and tried to do some events that were more outdoors and in venues that weren't quite like the ones I was describing. She did go back to see her allergist to revisit the concept of the allergy immunotherapy along the way. I'm going to pause for other thoughts. I can tell a couple more things about her, but if anybody else wanted to share.
I just wanted to say, I think that's because I'm hearing everybody talk about her, and what I hear are all these different areas that we could approach. The first being her allergies and allergies to things other than dogs. And we could start there. And it sounds like, Dr. McCormack, you started with the medication piece, which was right. So you started with what medications, and then, can you see your allergist again? And then can we change the venues that we're going to do? So again, not that, for her, not hearing, I can't do what my passion is how can we tackle this from different avenues to get a result? I think that's what shared decision making is, I think, overall, as you're addressing those things.
Dr. McCormack, I think another thing that people don't realize is that asthma can transition into COPD, and they think it's only smokers that can get COPD. And so I have these really low tech, this is a pool noodle here, a little segment of a pool noodle. And I put the rubber bands around the outside, and the mucus there, that's my plastic. I have the professional model, but a lot of my patients are really intimidated by that. And then I have just a paper towel tube, and then I show them the difference, what it looks like to breathe through these. And then at the very end, I say, if you remember nothing else from today, you do not want to be a pool noodle. And I talk to them about, if you can imagine injuring yourself in the same spot over and over again. Say you've got that coffee table, you keep banging your knee on it, you're going to build up scar tissue. So that's the same thing that happens in your lungs. You can't see it or you can't feel it, but you're going to change the actual shape of your lungs and have that permanent scarring and have to be on oxygen and carry a tank around. And, that's no fun. So
how to move forward, how to adapt, how to think about maintaining her ability to do this thing that she loves, that was also really seemed to be driving her asthma. And so some of them focused on medicines and then kind of tweaking her schedule and so forth. And to the point where every patient is sort of in charge of their own health and will, take your advice or do things. I think I am lucky to have a very good relationship with this patient. And she did pretty well. So, and then during quarantine and so forth, she's for a bunch of reasons, her job kind of had slowed down before then, and then it really paused. I saw her yesterday, and she's still having a lot of what I would say is a lot of symptoms, not these really scary events, but still has a cough most days, doesn't really use her inhaler very much, even though she has a cough most days. But she was very upset when I saw her yesterday because her husband was just diagnosed with prostate cancer, and they think it might be advanced. And so that's what we talked about for the first 10 minutes. And then we talked about this at our last session, but then I really talked to her about how this is a big stress, obviously, and that this could really trigger her asthma as well. And talked about how kind of she doesn't need anything else going on. So I was like, if you can, I would really try to grab your Brio and just try to take it every morning. To the extent that that's helped you in the past, and to the extent that that can just give you a little bit more of a buffer, so that if the stress happens to really make your asthma worse, then you can maybe try to head that off a little bit. And that was the conversation we had yesterday. And now we've kind of established that she's not someone who loves to take medicine, but I thought that this was probably a good reason to be more proactive than she otherwise would, because she has plenty of other things on her plate.
You know, I love that. And it absolutely, stress is going to trigger some asthma attacks if she's dealing with this cancer diagnosis with her husband. And, you know, oftentimes we'll tell people, if you just take this little tiny little amount of the inhaler, it's just going to go right to your lungs. But, you know, if I have to put you on prednisone, you're going to be getting dramatically more. That goes through your liver, your kidney, your heart. It impairs your immune system. And so you're just going to get that tiny little amount every day. And it's actually better for you and better for your lungs just to have that tiny amount each day. But sometimes that doesn't connect with people either or resonate with them.
And I think that Dr. McCormack, it just shows to go your expertise in this field of, you know, not just listening to how the patient's doing and the symptoms that she's having, but her as an overall person. And that, you know, these different things about her, right? Already from this short time, we know what she likes to do, and what's going on with her stress in her relationship now in her life, and, you know, things that she enjoys, and how we can look at that to meet her values. And I'm sure that she's going to do much better working with you than she would with somebody who's just going to, you know, look at her symptoms and say, well, how can we fix this?
Typical dog shows, the trainer does some fairly physically active jogging around the court with their dog. And I wonder if anybody would examine what her activities were. Maybe she'll have to give up the exercise portion of a dog show and let somebody else do that portion for her while she continues to do training or judging or observation or help with other tasks. I don't know if the amount of activity in the dog show is enough to precipitate her symptoms, but maybe she hasn't thought of that as a trigger.
That's an excellent point about how I learned a lot from her about how physically active you are in dog shows and in this profession. So she's not showing dogs, she's pretty much retired, but she has dogs at home. And when I was asking her about getting out, even sort of for the mental health benefits of getting out and conditioning and so forth, she said she walks 2 to 3 miles a day just regularly. And now that the spring's coming and she had some other stuff that she was going to do related to the dogs, like that she thought she would increase her activity probably by a couple miles a day. So I thought that was, you know, a good thing for those reasons, just for conditioning, mental health, and then also just, for all of the benefits of exercise. So that was one of those things that I just, people's habits influence their activity. And that was, you're right. It's a very physically, can be pretty physically strenuous.
Excellent. Well, in the interest of time, I just want to ask, was there anything else that you wanted to add about this patient, Dr. McCormack, before we get to our housekeeping stuff? Okay, great. Well, thank you everyone for your contributions to that really interesting case. Thank you, Dr. McCormack. So now we've got our post-test polling questions. If we don't have any questions that is from the group about the case or anything that was mentioned today, if you'd like, feel free to add those into the chat. So let's get started. Question 1. Which of the following is important when deciding on which biologic to select for a patient with severe asthma? Your patient's attributes and preferences, insurance availability, using a shared decision-making model, or all of the above? And question 2, which of the following is a benefit of shared decision-making? Patient satisfaction, improved asthma control, improved adherence to medication, lower healthcare costs, A, B, and C, or A, B, C, and D. All right, thank you, everyone. All right, Dr. McCormack, how'd we do?
Awesome. For the first question, everyone answered it correctly, which of the following is important? So the patient's attitude and preferences, insurance availability, using a shared decision-making model. These are all important when selecting a biologic therapy for a patient with severe asthma. And the second question, the benefit of a shared decision-making model, both answers were good, I would say. If we read all the way to the bottom, the patient satisfaction, improved asthma control, improved adherence, and then also lower healthcare costs, which have been shown to be a benefit of shared decision-making. So great job.
Excellent work, everybody. Thank you so much. All right, so of course, next week is our very last session of this boot camp where we'll talk about administering injectable medications. We get into the biologics, into the nitty-gritty of the biologics a little bit more. So would anyone like to share a patient case for our last session? All right. Well, I'm sure that Dr. McCormack will have another wonderful and interesting case for us next week. If anyone changes their mind during the course of the week, please feel free to reach out and let us know. Otherwise, I just want to say thank you so much to everyone for joining us today. Thank you to our wonderful hub team. Echo Cloud to everybody. I hope that you all have a wonderful week. Thanks, everybody. Bye-bye.